Welcome all of you to this live program of Big Principles. Today, our guest of honor is Professor Michael Hantes from Larissa, Greece. Professor Hantes is a professor of orthopedic surgery at the University of Thessaloniki in Larissa, Greece. Dr. Hantes completed his medical degree at the Aristotle University at Thessaloniki in 1990. He trained in orthopedic surgery at the Anina University Hospital, followed by fellowship training in sports medicine and knee arthroscopy at Heidelberg in Germany, and upper extremity and knee arthroscopy with James Shaw in the United States. Professor Hantes is the founder of the Larissa Arthroscopy and Mineral University Center and organizes seminars in arthroscopic surgery. Clinical practice and research of Professor Hantes includes knee and shoulder surgery. He's been the president of the Greek Arthroscopy Association and Sports Medicine. Dr. Hantes is an active member of the ESSKA, where he has served as treasurer, secretary general, and currently serves as the second vice president of ESSKA. If you've noticed, Professor Hantes has delivered a lecture on our channel in the past, and today is my great honor to bring back Professor Michael Hantes for this wonderful live program. Over to you, Prof.
So, dear Hantes, it's really very nice and a big pleasure to be with you again. Thanks once again for the invitation for the orthopedic principles, and I would like to congratulate you for the amazing job and the effort you put in orthopedic principles. So we're going to talk about the extra-articular lateral tenodesis, or the extra-articular procedures for ACL reconstruction, when to do it, how to do it. This is a special topic, and it has been popularized in the last, I would say, 10 years. And we're going to see and discuss the options, the tips and tricks for do it in the right way. So these are my scientific disclosures. I'm associate editor for the JBJS connector cases and editorial board member of American Journal of Sports Medicine, knee surgery, sports traumatology, and arthroscopy, and GSACOS. So as you all know, anterior cruciate ligament reconstruction is performed not to control only anteroposterior instability, but anterolateral instability as well, because as you can see, the native ACL controls anterolateral instability as well. So when we have an ACL rupture, as you can see, the normal knee has a normal internal rotation, tibial internal rotation of around 10 degrees. However, when you have an ACL tear, then the tibial internal rotation increases up to 23, 25 degrees. So there's a big difference in increasing internal tibial rotation. And that's why the center of rotation changes and it moves more medially. And that's why the lateral compartment has bigger mobility. And if you have, in addition, some anatomical, let's say, pathology like increased posterior tibial slope, then this mobility of the lateral compartment increases more than normal tibial slope changes. So most probably in many of cases, not in all cases, you have a combined injury to the anterior cruciate ligament and the anterolateral structures, and this has been underestimated in the last years, but it could be a combined injury to the anterolateral structures, and this could contribute to anterolateral rotator instability. And that's why in these cases, when you don't deal with this combined structures reconstruction, you have a failed in your ACL. So let's see the composition of the anterolateral complex. This has been studied in many anatomical and cadaveric studies, and this nice study from a group of Bernardson and Ricotet describes that there are three layers of tissue: the superficial iliotibial band and the iliopatellar band, the deep capsulo-osseous layer of the iliotibial band, and the anterolateral ligament, which has been described many years ago, but it has been rediscovered, as we will see later, 10 years ago. This has been described recently by Stephen Klaes from Belgium, and that's why there was a big interest in reconstruction of this ligament, in anterolateral instability of the knee, as we said before, in the last 10 years. We had a similar experience in our university, so we dissect a big number of knees, and as you can see, we discovered the anterolateral ligament in all these knees, and as you can see, it's under the iliotibial band, and when you trying to do internal rotation of the knee, this structure is under tension, which means that it contributes to limit internal rotation of the tibia. So it's a structure that it exists, and based on your belief, it could be the main structure that contributes to the anterolateral stability, or according to some other people, it could be the iliotibial band, which is more important to contribute to the anterolateral stability. So there are a lot of controversies, but at least based on some biomechanical studies performed by Andrew Amis, the group of Andrew Amis in Imperial College London, it seems that the iliotibial band is the strongest part, and this which contributes more to control the anterolateral stability of the knee. The same goes for this paper, which comes again from the group of Andrew Amis, and they reported that the iliotibial band is the most important structure for the restraint of anterolateral rotatory knee instability. However, there are some other papers like these two papers, which report that the anterolateral ligament reconstruction has the same results like the extraarticular tenodesis, the Lemaire modified procedure, and there is no difference between the anterolateral knee stability, either if you reconstruct the anterolateral ligament or you do a lateral tenodesis. So you can believe or be with one or the other opinion, but it seems that both of these structures reduce, if you reconstruct it, significantly the amount of instability, the anterolateral instability. However, it's not just the ALL or the iliotibial band, but it seems that it may play a role, the bony anatomy and osseous lesions. As you know, sometimes we may have some anterolateral impaction, and like in these cases, or even it could be in some cases even more pronounced, like in this case, and it could be an equivalent lesion to the Hill-Sachs lesions, and this could be, in addition, magnifies the anterolateral instability as well. The second fracture could be another possible lesion which contributes to the anterolateral instability, and it could be equivalent to an osseous Bankart lesion. And we know from the shoulder surgery that you have to include in your repair this bony part in order to have a stable shoulder. So why not to do the same for the knee? And as we said before, there are some other factors like anatomical factors, that like the increased tibial slope, which contributes a lot to anterior and anterolateral instability, and we have also to take into account all these factors when we have to reconstruct the anterior cruciate ligament. Probably because of all these factors, we had in the past some unacceptable, I would say, rate of a rupture or remaining instability or low return to sports. As you can see, 15 to 20% of remaining instability, higher ATR rates, and return to sports in many athletes around 67 to 70 degrees, which is, I would say, not acceptable. When you have 20% failure rate, this is not acceptable for a surgical procedure. That's why we should think that we have to reinforce our ACL reconstruction in order to improve these results. And that's why the lateral tenodesis or the ALA reconstruction became, in the last 10 years, a very common procedure. It was described many years ago by Marcel Lemaire in France. And after his description, we had some modification of this extra-articular tenodesis, the McIntosh procedure, the Ellison procedure, the Arnold procedure. But it seems that for most of the surgeons, the most popular is the modified Lemaire procedure. How to do it? You have to strip the central part of the iliotibial band. The strip should be around 10 millimeter wide and 8 to 9, 10 centimeters long. And you should leave the insertion to the girded tubercle, of course, without detach it from the girded tubercle. And then you have to identify the lateral collateral ligament, pass it under the lateral collateral ligament. This is the key part of the procedure, and fix it in the best isometry position, which seems to be, according to most of the studies, 10 millimeter proximal and 5 millimeter posterior to the femoral insertion of the fibular collateral ligament. Of course, there are a lot of ways to fix your iliotibial band: screw, anchors, staples. However, my preference is screw fixation because I think it's the strongest and the most reliable fixation. It gives you a reliable result in terms of stability, and you don't have to do an extensive procedure like if you use a staple and you have to detach sometimes the vastus lateralis. We just published a paper and which is a technical note and describes very well how to do this procedure. And this has been published in ESSKA, in the ESSKA journal very recently. And we're going to watch the video in order to get familiarized with the procedure. So let's watch the video.
In this technique, you will see how to avoid tunnel collision when performing lateral augmentation procedures along with anatomic ACL reconstruction. We have no disclosures. The ideal patients for this operation are young patients with high-grade pivot shift or generalized laxity. Indications also include patients participating in pivoting sports, increased lateral tibial slope, or revision ACL cases. On the other hand, chronic tear and concomitant meniscal repair are considered relative indications. Contraindications include lateral compartment arthritis or posterolateral corner injury. General or regional anesthesia can be used. Prophylactic antibiotics should be administered. A tourniquet can be also used. ExtraArticular tenodesis is an open procedure. However, the use of the anteromedial portal is important, as we will see later in the surgical technique. Patient is lying supine. His knee is flexed in 90 degrees. Our incision is starting 1 centimeter proximal to Gerdes tubercle and extends over the lateral epicondyle. Approximately 7 centimeters are needed. After dissecting the subcutaneous tissue, the iliotibial band is exposed. The central 1/3 of the iliotibial band is carefully harvested. Width of the graft should be minimum 1 centimeter. Length should be approximately 10 centimeter. And we have to make sure that the most posterior fibers of the iliotibial band are left intact. After successful harvesting of the graft, the proximal side is sutured with a number 2 fiber wire using the Krakow technique. Finally, the diameter is measured. The lateral collateral ligament is identified by palpation by placing the leg in the figure of 4 position. A small incision is created proximally and the graft is passed beneath the lateral collateral ligament. And now comes the hard part, which is also the novelty of this technique. The area just proximal and anterior to the lateral femoral epicondyle is cleared by soft tissue. A guide pin with suture eye is positioned. When performing the femoral tunnel, stay safe and avoid tunnel convergence using appropriate aiming in your drill guide. You have to choose your angle between the following appropriate combinations: a coronal angle of 10 degrees with an axial angle of 40 degrees, a coronal angle of 5 degrees with an axial angle of 35 degrees, or a coronal angle of 0 degrees with an axial angle of 30 degrees. Then, the scope is advanced inside the femoral ACL tunnel through the anteromedial portal, and in this way, you can check intraoperatively the integrity of your tunnel. Finally, fixation of the graft in the femoral tunnel is performed. The graft is advanced inside the tunnel, and an interference screw of appropriate length is positioned. Intraoperative visualization of the ACL femoral tunnel is the novelty of the presenting technique. The advantage is that in case of collision, you can correct your orientation without damaging the ACL graft. Post-operative rehabilitation and return to sport guidelines are briefly presented. We would like to thank you for watching this technique.
So I think, I hope it was helpful. This video includes all the tips and tricks in order to do it in the right way. As we said, you may use suture anchors. I try to use suture anchors in children with open physis, and you have to plate it just below the physis under fluoroscopy. It's better in order to be 100% sure that your anchor is placed in the right position. Otherwise, in most of my cases, I prefer the screw. You already saw the indications. Let's repeat it once again. High-grade pivot shift test, generalized laxity, the increased lateral tibial slope, young patients, especially this group of patients, has a tendency for high rupture rate. So in almost all my cases for young athletes under 19 years old, I'm reinforced my ACL reconstruction by lateral tenodesis. Revision cases, almost 100% of my revision cases, and high demand and pivoting sports. Relative indications are chronic ACL tear, meniscal loss or meniscal repair, and second fracture. We can discuss it at the end, but there is a controversy if we have to do lateral tenodesis or ALL reconstruction in all patients, if it's a kind of overtreatment or not. But once again, we can discuss it at the end. The value of this procedure is most probably the low re-rupture rate that has been observed after this operation, and this is probably the most reliable study with the best evidence, multi-center study, the so-called stability study, which reports that there is a 4% re-rupture rate in patients who had lateral extra-articular tenodesis, in contrast to 12% in patients that had just isolated ACL reconstruction. Of course, you can find many studies out there which reports that the re-rupture rate is really very low after lateral tenodesis, but it's not necessary to report all these studies in this presentation. There are some issues or unsolved questions, especially with the overstrain or in the lateral compartment, and if this is a risk factor for development of lateral compartment arthritis. This is a courtesy of Professor Hewlett. As you know, in France, the lateral tenodesis was very popular, and as you can see, this patient who underwent a lateral tenodesis developed lateral arthritis in the lateral compartment, and this is an issue. Let's see what is the evidence around this topic. This study reported that indeed the patients that had combined bone patellotendon bone and lateral tenodesis developed lateral compartment osteoarthritis more frequently in comparison with patients with isolated bone patellotendon bone. However, as you can see, the graft failure risk was much lower in patients with combined ACL reconstruction and lateral tenodesis. However, the evidence let's say, the current evidence report that there is no risk of osteoarthritis, lateral compartment osteoarthritis, if you combine your ACL with lateral tenodesis, and this is a systematic review performed by Julian Feller and his group, and reports that there is no risk of lateral compartment arthritis. In contrast, concomitant lateral meniscectomy is a major risk factor for developing osteoarthritis after ACL reconstruction and lateral tenodesis. And this is the results of the group of Sonnery Cotet, who performs and prefer most of the times the ALL reconstruction. As you can see, he uses a part of the gracilis graft to do his ALL reconstruction, and he reports more or less similar results in terms of graft rupture. And this is his latest publication, and he reports that there was no increase in the risk of lateral compartment osteoarthritis in patients who underwent isolated and ALL reconstruction. So this means that the anterolateral ligament reconstruction or the lateral tenodesis did not increase the risk of osteoarthritis. So in conclusion, I could say that the anterolateral procedures, in order to augment or to reinforce our ACL reconstruction, it's a new era, I would say, in ACL reconstruction. Just the last 10 years, it's something that has been increased, popularized, and discussed. We definitely have a better control of anterolateral instability by adding these procedures. We do have better clinical results in terms of return to sports and lower rupture rate. We still have to wait to see if there is a risk of over treatment and osteoarthritis in these patients in the long-term follow-up. Hopefully, in 10 years from now, we will have a definite conclusion if there is a risk of lateral compartment arthritis or not. And it's something that in the future we will decide if we have to do it in every patient or if this is a risk of overtreatment. It's a matter of philosophy. It's a time of an ethical issue. If I have to do it in every patient, since some of them would probably don't need it. But on the other hand, someone can say that since I have a procedure in my hands that improve my results, why not to do it in every patient? So I would like to thank once again for the invitation, and I would like to invite you in the next ESSKA Congress next May in Milan 2024. Thank you very much.
Thank you very much, Prof. Thank you very much, Professor Hantes, for this brilliant presentation. And let's have a short question and answer session, Prof. Prof, when do you decide preoperatively whether you're going for a lemma? For example, you have mentioned about indications in a less than 20-year-old patient, a chronic ACL, you're going to do straight away, you're going for a lemma. Suppose the patient is, say, 30-year-old and 6 weeks old injury. So do you decide preoperatively, or do you decide immediately after anesthesia, you look for the pivot shift, you see a grade 3 pivot, or after you do the ACL, you put the femoral side and tibial side screw, and if there's a persisting pivot, you go for a lemma. So when do you decide?
This is a very good question, Hantes. This is a very good question. I think in almost every case, I decided preoperatively. For example, if I have a patient with a grade 3 pivot shift test, if I have a patient who is doing a high demand sport, in most of the cases, if not, I'm doing a lateral tenodesis. If I have a patient who does not he's not so active or she is not so active, and he or she does not participate in intensive sports, let's say, then the instability it's not so gross, then I would most probably not do a lateral tenodesis. It is my belief that not every patient needs a lateral tenodesis, but once again, when you discuss this topic with people who are in favor of doing the lateral tenodesis in 100% of patients, they say that since you have a procedure which really improve your results, why not to do it in every patient? So it's a matter of ethical issue, philosophical issue. We'll see. But it is true that the feeling you have when you examine patients with ACL reconstruction, a lateral tenodesis, in terms of stability, it's really very, very good.
Thank you very much, Prof. And
just
Prof,
to give you my, let's say, evolution in my personal practice, 8-9 years ago, I did just 20% of lateral tenodesis. Nowadays, I'm doing almost 70-75% of lateral tenodesis in my primary ACL reconstruction.
thank you very much, Prof.
So,
Prof, regarding the technical tip, so sometimes do you have any difficulty in identifying the fibula collateral ligament? Is there a risk for an injury?
No, I don't think so. I don't think so. Actually, it's a very quick procedure. If I can give you a trick, you have to palpate the lateral collateral ligament in the figure of 4 position, and then you go in front of the lateral collateral ligament and make a small incision in the soft tissue, and then you can easily identify the lateral collateral ligament. Actually, from a technical point of view, it's a very easy and straightforward procedure.
Thank you, Prof. Hantes. Prof, we also joined by Loy. Loy Al-Khatib is an orthopedic and sports medicine surgeon based in Dubai.
Welcome,
Loy, welcome to the show. And your questions.
Oh, hi.
Hi.
Hi, can you hear me, guys?
Yes,
Yeah,
please.
absolutely.
Thanks a lot for the great presentation. I think this topic is trending now. everyone is talking about. I attended ANA in New Orleans last month, and everyone is talking about LET, ACL reconstruction plus minus LET, when to add LET, when not to add LET. My question is to you, the hyperlax patients, these patients that, I do have a patient now, she had ACL reconstruction a couple of years ago. The surgeon took, she has a hyperlax, vital score is really high. And if I show the picture, she can bend her fingers almost all the way down up to her forearm and so on. And he took her hamstrings. ACL is ruptured again, it's failed. So I'm planning to revise her. So I'll check an allograft and planning to add LET. My question is, would you think this is a wise decision to take an LET from her IT band? We know that the IT band is it will be lax as well. And the other one, how do you make sure that this is the isometric point when you do the tunnel for the LET?
Well, I think in this case, I would definitely add an LET. In most of my revision cases, if the hamstring graft has been used before, I'm taking the bone patella tendon bone, and then I'm doing the LAT in the normal way. Of course, the isometric point, as you said, it's a matter of debate. The best isometric point is 10 millimeters posterior and 10 millimeters
proximal
and 5 millimeters posterior to the lateral epicondyle. And as I told you, I'm using always a screw in order to have a stronger fixation. And I'm using this trick by putting my scope in the anteromedial portal, checking during drilling with a guide wire if there is a collision with my ACL tunnel. And then gradually I enlarge the tunnel with most of the times 5.5 or 6 millimeter diameter drill bit for 20-25 millimeters. And believe me, I had no problem with tunnel coalition. Actually, we're now in the process of evaluating these patients with computed tomography to see with an objective way as well the distance between the tunnels, because as I told you, intraoperatively there was not even a single case with tunnel coalition.
So again, if this is the hyperlax patient, would you use an autograft, still use an autograft, or would you prefer to use an allograft for her?
Usually, I'm using, in most of my cases, autograft.
Okay. And do you think adding, for these cases, adding a modified Lateral procedure would add more stability to the lateral structures, to the anterolateral stability? Modified Lateral procedure would...
Yeah, you know, if it's the lateral structure are well preserved, I'm not sure if the Laparat procedure will give you more stability in the lateral compartment, but you cannot be 100% sure if, especially in hyperlax patients, if the lateral structure are well preserved. I mean, the popliteus, the popliteofibular ligament. So it could be a good choice to add a Laparat procedure or an RCRO procedure in order to make it more simple in these patients.
Awesome. Thanks a lot. Very interesting topic, very interesting talk. And the discussion, I think, will keep
Thank you, Prof. Hantes. That's all the questions that we have for the session. Thank you for this wonderful presentation, and we really look forward for more in the future.
Thank you very much once again. I wish you the best, and once again, congratulations for your scientific work in orthopedic principles. It was nice to see you.
Thank you very much.
Bye-bye.